All right. So today we're going to talk about optical coherence tomography, the macular of the ocular OCT of the posterior segment, and how we interpret OCT. Now, I've given this course for the past few years, so it's more or less the same course with perhaps a little bit of a few changes. This course is intended to be interactive, so I'm going to try to pay attention to the chat. If you find that there is something that you don't understand, so let me know, so that I can stop and make things clearer as much as I can. Okay, so I would like to know that you are seeing my screen. Is everybody seeing my screen?
Yes.
Okay, perfect. Okay, so what is OCT? Now, it's an imaging technique that was introduced about 20 years ago. And it's, or perhaps even more than that, 30 years ago. It's indispensable for the diagnosis and the follow-up of retinal pathologies. What it does is it provides a cross-sectional image of the retinal anatomy. And how do we get this image? Is by light that we project onto the retina, and then the light is captured by the retina and brought back into our view, via special equipment. And this light will, translate and come back with the different speeds, and according to the speed that the light comes back, we can decide on the reflectivity of a tissue, and then we can see the tissue a little bit better. So it's very, very similar to MRI, CT, and ultrasound, except that we use light instead of using other wavelengths such as sound. All right, so where do we apply OCT? Well, now I'm telling you this, there is no retina specialist that can do anything without an OCT, because it provides so much more information than just looking at an eye. So we use it to establish the diagnosis of macular pathologies, or even retinal pathologies. We use it after we administer treatment to see if the course of treatment that we've given is beneficial or not. Therefore, we monitor the treatment efficacy. And also we can see the retina so clearly and see the microstructure of the retina so clearly that we can determine, the prognosis of a certain disease, but also, how did this disease happen, the pathogenesis. So how is the outline of this course? At first, I'm going to tell you a little bit, just a little word so that we don't take too much time. How does an OCT work? What is the basic principle? How do we acquire an OCT? And then, how do we analyze an OCT? And as you know, there are two ways of analyzing OCTs. We can either use the measurements, that is a quantitative analysis. And so I'll tell you how to see that if you have results come to you, and how do you recognize the measurements on an OCT, and what makes sense and what doesn't make sense. Are there any artifacts that make the measurements completely false and completely unusable? But also, most importantly, the qualitative analysis of the OCT. That is, we're going to look at the retinal layers, layer by layer, and we're going to try to understand together, what are these pathologies, starting with the vitreous, the interface between the vitreous, the retina, the inside of the retina, the RPE layer, and then even the choroidal pathologies. Okay, so how does OCT work? Now, OCT, as I said earlier, it depends on the optical reflectometry, which means that we shine light, from a source. And this source basically goes into both the eye and also a mirror. All right. And then the light, of course, when we shine light at an eye or at a mirror, the light comes back to us. So when it comes back to us, it's going to go through a beam splitter. Okay, and the beam splitter is going to basically send the light back to a detector, and it's the difference of the speed of light from the mirror and these tissues that we image that is going to give us the image of the retina, and this is by the interferometry. Okay, so how fast the light comes back from the tissue will basically reflect the reflectivity of the tissue. So what we have is that the OCT is actually a cross-sectional image of the retinal microanatomy defined by the light that returns from these tissues. Okay, so and what we do is we have several B scans right there, several A scans several A scans that come in, and you can have them come in very slowly or all at the same time, such as we see here, like in the modern OCT machines, and we can construct a B scan from these series of the A scans to give us this beautiful image. All right, so that's all what you need to know at this point. We're not going to go into the details, but I need you to know one thing is that in the past, the very first machines were time domain OCTs, where they were actually quite slow and they could not do any averaging, and there was no possibility of doing eye tracking. But the common machines that we use now, you see, this is the kind of image that we used to get with a time domain OCT, but now we use much faster machines, and we call them Fourier domain or spectral domain OCT, SDOCT. This permits to get a very high resolution, permits tracking and permits averaging. Now, you may ask me, what is averaging? Well, averaging is when you take several shots, okay, or several exams of a specific area, okay, and then put them all together, collide them all together. And so anything that is extra that doesn't correspond, that you don't see on every single image, is taken out, and any image that you, or any detail that you see on several images is actually taken in, and then you get something that is of a much crisper quality than images that have a lot of noise. Okay, so the spectral domain OCT machines permit to do averaging, which means that you get a crisper image, you have noise reduction, and because of this, you can also determine with the machine that you want to image a specific area, and then the next time you want to image, you image exactly that same area, and it basically can correspond, the previous images with the new images and tell you whether there is any change. All right, so that's what eye tracking is about. Now, so here again is an example. If you just do one frame, this is what you get. You get a noisy image, but if you get multiple frames after averaging, you get a much crisper image. Okay, now we're going to talk about the standard OCT, all right? But know that you can also do what we call an enhanced depth imaging OCT, which will focus the image much more on the deeper tissues, that is the choroid, rather than the retina. Know that in the standard OCT, the focus is primarily the retina, so it starts from the vitreoretinal interface and ends at the RPE, Brooks membrane complex, and anything that is below it may not be complete. But in enhanced depth imaging OCT way of doing things, then you get a crisper image of the choroid, and the retina may not be as clear. Okay, so basically you move the focus a little bit more inwards. In a swept source OCT, this is available commercially and is available in certain hospitals. You have a very, very nice penetration, and you can image very nicely both the vitreous and the retina and the outer retina and the choroid and the sclera. So this gives you a full through and through image very nicely. And excuse me, if you have adaptive optics OCT, this is a very ultra high resolution that you can use to determine, the health of individual cells, but it's primarily for research, it's not for clinical use. So let's go back to very quickly look at the retinochoroidal anatomy, just the boundaries for now. We're going to talk about the anatomy in a little bit later when we talk about the qualitative interpretation. So as you know, the vitreous is this hyporeflective cavity. Hyporeflective means you don't see, it's dark, okay? There's nothing that reflects from it, right? The reflectance is reflectivity is what we use when we talk about OCT, okay? Now, in the fluorescein angiography, we talk about fluorescence, okay? In OCT, we talk about reflectance, okay? These are the proper words to use. So you have here the vitreoretinal interface, which is the limit between the inner retina and the vitreous. And then you've got the RPE Brooks membrane complex, which is the basal lamina of the RPE, okay, where the RPE sits on the Brooks membrane. This is the RPE Brooks membrane complex, and anything in between is really the retina. So starting with the RPE layer and then the rest of the neurosensory retina. And then you've got the choroid right there, which is determined between the RPE layer and the choroid scleral junction. You know that this is a choroid because you've got a lot of hyporeflective spaces here that denote the presence of large choroidal vessels, and you know that this is sclera because it is hyporeflective, but you can see that there are no vessels going through this. As you probably remember from anatomy, the sclera is a tissue that is made primarily of collagen fibers, and we're just that doesn't have any proper vessels in it. So this is the rather homogeneous hyperreflective tissue. This is the sclera. So anything in between, this is the choroid. This would be the choroidal junction, and this is the sclera. And then here you have the hyporeflective vitreous. So this is what you're going to remember for now. We're going to go into more details a little later. So how do we acquire an OCT? Well, typically we do it with the patient sitting up, and I'm sure that you've all seen this. The operator uses a machine, the patient sits up, puts the chin in the chin rest, and takes the images. But you can remember that you can also do an OCT with a handheld device. Okay, if you in supine patients or in children, for instance, you can have intraoperative OCT that can be also handheld, used, during the or just before the operation, before and after, to see if you want to look at the macular pathology in more detail. But nowadays we can also have OCT integrated with the surgical microscopes that can help the surgeon while they're doing surgery to visualize, what they're peeling and where they're and at what depth are their instruments in. Okay, so how do we acquire the OCT? Now, with everything, like with the photos, just like with, autofluorescence and fluorescein angiography, if you don't do the acquisition according to a standard protocol, okay, then you don't know what you're interpreting, right? So you have to have a specific protocol, so that you can have a basis for interpretation. So the acquisition protocol will first, we do what we call a horizontal line scan. This is the line scan. This is what it's called. Okay. Now you can have a single line scan, or sometimes for instance, in a Zeiss machine, it actually gives you 5 lines. Okay, with the middle line being the most high resolution. What does that mean, high resolution? That means the image, the OCT image took this line, okay, imaged this line 20 times, okay, 20 times, and then it put all these pictures together, and it took out everything that is not consistently seen on every picture, and retained what is consistently seen on every picture, making it, doing the averaging process, and therefore you have a very high resolution image, a very crisp image. This is the crispest image that you can get, is with a line scan. Now the line scan is usually horizontal, but also vertical, okay, going through the point of fixation. Now you can put this line wherever you want, but generally the protocol is the patient fixates a specific target, and then the operator does the, takes several pictures, several takes, let's put it this way, of the macula, both horizontally and vertically, passing through the line of fixation, and you get a very high resolution image. Then we do what we call the raster scan. And here I'm showing you a picture of a horizontal raster scan, but you can also do a vertical raster scan, or what we call a volume scan. In this case, the machine is going to take, the patient fixates, and the machine takes several takes, but usually one take per line. So it's not very high resolution, okay? It takes several lines. It goes for, scans the macula, in a 6 by 6 millimeter square, to take these lines and basically make averages, computate averages to measure thickness and volume. Okay, that's a horizontal scan. Okay, and sometimes in certain pathologies, for instance, if you want to detect, a specific detail on the fovea or on the line of fixation or any other area that you want to really look at very specifically, you may want to do a radial scan. That is a series of lines that pass through a specific area to see the area from all angles, to see, for instance, if you have a macular hole or you suspect a macular hole, you want to see whether it's full thickness or not, you may do a radial scan. Okay, this is optional. We don't do it all the time. But the volume scan is very important because that's the one that's going to generate the map. Okay, and then what the machine does, it's going to calculate the retinal thickness. So how does it do that? Well, the machine is pretty clever. The software is going to put a line on the inner limit of this membrane, of the retina, that is where the vitreoretinal interface is, and we're going to call this the ILM, or the inner segmentation line. Okay, you need to know this word, segmentation, and it's going to put a line at the Brooks membrane and the RPE, Brooks membrane complex, and that is the outer segmentation line. And then the machine is going to calculate the thickness at every single point in here and generate a map. Okay, generate a map of thickness and on volume. So it's very important that the machine puts these segmentation lines at the correct place. Okay, if these are not correctly placed, if the machine makes an error, then you have different data of thickness and volume, and that's not going to be okay. Now, calculating retinal thickness, you also have to know that the retinal thickness is going to depend on the machine. Each software is programmed differently. In a Stratus machine, the thickness stops really at the ellipsoid zone, okay? In a Cirrus machine, Zeiss Cirrus machine, it stops at the apex of the RPE, and in the Heidelberg machine, which is what we have, the Spectralis, it really stops at the bottom of the RPE Brooks membrane. So these are the machines that generate the highest thickness, okay? What is considered normal, 280 microns for a foveal. For a central macular thickness, for instance, this is considered at 280, but for instance, for Heidelberg, 300 can also be considered normal, all right? So it's important to know that you cannot compare thicknesses between machines of different models, all right? Now, so we said that the machine is going to, do all these lines, generate a map, generate the thickness, and this is what a map looks like. So you have an SLO, rendering of the en face of the face of the macula, and this is the limits of the scans. This is where the lines took place, okay? And this is going to be color coded for easier understanding. So here it is, color coded, showing the center of the macula and perhaps an area of increased thickness in here. Okay, and if you want to know the exact number, the exact thickness, well, they're going to look at this. Okay, everything that is in black is actually thickness. Okay, and everything that is in red is actually volume. So it gives you the idea of the volume of the central field, but also of the average thickness of the central field. Okay, now here are the EDTRS subfield. You have the central subfield thickness, and then you have the inner subfields, superior, temporal, inferior, and nasal subfields. Okay, and then you have the superior, temporal, inferior, and nasal external subfields. This area, this circle here, has a diameter of 1 millimeter. Okay, this circle from here to here has a diameter of 3 millimeters. So 1 millimeter, 2 millimeter, and 3 millimeter. And then here, from here to here, at the edge of the circle has a diameter of 6 millimeter. Remember, we're doing 6x6 scans, so basically 6 millimeters. So and the machine will give you really a good idea of each of the thickness and the volume of each of these areas, okay? So these commonly used measurements are the central point thickness. This is, for instance, I think it's here, like it tells you that the point thickness at the fovea is like 298 millimeter. It'll give you the central subfield thickness, which is the whole thing right there, 342 microns, and then the additional subfields as we mentioned right here, okay? So it gives you also a volumetric analysis. And in certain, you can also do, if you do the segmentation, for instance, only on the outer retina, that will also generate a map on only the outer retina, depending on where you put the segmentation lines. Okay, so do you guys, what time is it? Let me see. I have no idea. Okay, but it's about prayer time. Do you want to stop now and we meet in 10 minutes? Is that okay? Hello?
Yes, it's okay. Thank you.
All right, so let's meet in 10 minutes. Let's pray Asr very quickly and come back. Okay, take care. Is back. Okay. Taqabbal Allah for everybody. And okay, we're going to continue now. Let me just take this off here. Okay, so now we're going to talk about how we analyze OCT scans, and first by looking at a quantitative analysis and then the qualitative analysis, which is what we mostly use in clinic. So the quantitative OCT interpretation, this is used when you need to have measurements. And like, for instance, if you have clinical studies ongoing, you need to have some kind of a measurement to generate data and be able to computate those. So those are the ones that we generally use in studies, okay? But of course, it can be used for an individual patient. If you are following a patient and you want to see the thickness, for instance, you're treating somebody who has, like, for instance, macular edema, you're treating this patient and you want to see if the thickness is increasing, decreasing, you may also use these maps, provided that the map is taken at the exact same position. Otherwise, you will not have the same, data to compare with. So this is what we use when we say quantitative. That means we look at the measurements. Okay. Now let's say let's see, for instance, if you have a machine that is a Zeiss, okay, a Cirrus machine, the first thing that you do, the machine is gonna generate something like this for you, like this sheet of paper, okay? The first thing that you do is you're gonna look at the strength signal, okay? Because you wanna make sure that the signal, that the exam was done in proper way, and that the patient was fixating and there were lots of artifacts. Because if the patient was not fixating well, you're going to have a low output, and you're not going to be really to trust the data that is generated. So the signal strength is very important, and here it's 7/10. That's reasonable. So you look first, was the exam done in a proper way? And then what you do is you're going to look at the SLO, the fundus image. This is the scanning laser ophthalmoscope generated, computer generated image of the surface of the retina that's going to delimitate for you the 6 by 6 millimeter cube, in which you did the raster volume scan. Okay, and therefore it's going to require that you do a volume scan. You cannot generate the data like this if you just do a line scan. Remember, we talked about performing first line scans, vertical and horizontal, and then performing volume scans. So this volume scan is going to generate a computer-generated image of the surface of the retina, okay, and in which you have the values for each subfield, which is what we talked about before the break, okay, in values of thickness in this case, okay. And then it's going to also generate for you a map, okay, that is color-coded for easier recognition, okay, with the red being, red or white being very highly reflective, very thick, okay, with the yellow and green being a little bit of medium reflectivity, with blue being dark and low reflectivity, or if it's really, really dark, then you have, basically no data, such as like vitreous, for instance, okay? So, and then it's going to give you the line scan. So it's going to show you what the line scan looks, the high resolution line scan, both the horizontal and the vertical, okay? And then it's going to also give you the thickness maps between the ILM and the RPE, that is just the retina, if you want, okay? Or if you do specific segmentation, for instance, it's going to give you what the surface looks like at the ILM level, whether what it looks like at the RPE level. For instance, here you have the RPE that doesn't have any ups and downs, so it's pretty flat. But here in the ILM you have increased thickness, so you can understand that the thickness was mostly generated within the retina and not from the RPE. It's not the RPE pushing forward, creating this major thickness. No, it is actually inside the retina above the RPE. And here, if you want specific, data, then you can also get the central subfield thickness, which is right there, 364, for instance, okay? And the cube, the volume, how much thickness is or volume is there in that cube that you took and elsewhere, okay? So we here at Kekish, we use a Spectralis machine, the Heidelberg machine. So let's go through this. So this is what the output generated will look like. The first thing is you have here the horizontal, you've got the SLO image, right? And then you've got the horizontal line scan with the boundaries clearly delimited. This is the boundary, this is the upper boundary, and this is the lower boundary of this 6 millimeter cube. And then you're going to see that it has an arrow, okay? An arrow with an arrow tail and an arrow head, telling you that the scan went this way. And this is very important because you're gonna need this. You're gonna have to know that the arrow points always towards the right when you examine specific line scans here. What it does show you also, it will show you where the segmentation lines were placed. So here, this is a line scan within the volume scan at this level. It's not high, it's not down, it's really in the middle, taking at the center of fixation, with the arrow being this way. And the machine tells you, listen, we've put the segmentation line here, we've put the segmentation line down here, and you verify, you say, yes, well, they were correctly placed, okay? There's no up and down, the machine did not make a mistake, put the segmentation line up here or down here. No, it put it exactly at the junctions, at the vitreoretinal junction up here, and at the between the RPE and the choroid right here. Okay, so segmentation lines are very clear. Okay, and then it will give you, you will know that you have you have to imagine in your mind that there is an arrow. It isn't there, but you have to know that the arrow always points towards the right. Okay, so this is the arrow tail and this is the arrow head, and the arrow always points by convention always towards the right. So if I show you an image like this with no arrow, do nothing, okay, you need to know that the arrow is on the right. So you look at this SLO machine, where is the arrowhead? The arrowhead is nasal, and you know this corresponds to this area here. Okay, all right, so in addition, it's going to show you the thickness map, you know, on top of this SLO image, which is right there, again, repeated right there, and is going to give you the different volumes and thicknesses of each subfield. Okay, this is how we read it. Okay, now the Heidelberg also can display the thicknesses at each specific point. Okay, you can generate a thickness graph. Okay, and for instance, here you have an eye that has macular edema. The segmentation lines are placed correctly, as you can see there. Okay, here they are. And it'll show you that this area, specifically this area here, you know, has a thickness of somewhere between 580, for instance. At this level, the thickness is 580. You move the cursor a little bit here, and we'll show you the thickness at each point. So that is very important. And here you have the arrow going upward, okay? This tells you that this area here, the right part of the arrow is the arrowhead. And since the arrow is up, that means this part is superior, and this part is inferior, okay? So this tells you that this is inferior retinal thickening. This is how we do it by convention. Do you have any questions about this at this point? Does anybody have any questions? You can unmute yourself or write it in the chat. Otherwise, I'm just gonna go on. Okay, all right. So no questions. So how do we quantitatively, you know, interpret this OCT? Well, again, as you know by now it's going to depend on the correct acquisition, okay, technique, and the correct segmentation by the machine. And of course, errors are possible due to poor, you know, technique, or because there are artifacts that must be recognized. What are these artifacts? You know, these are software breakdown. That means the machine did not put the segmentation accurately, or misalignment, or blink artifacts, if patients don't fixate and blink during the test, or if they move during the test, or if you have a mirror artifact. This is when you have the focus is not placed correctly on the retina, or out of range, when the you know, basically the operator takes a volume scan in which some areas, you know, are not taken, basically not computed, or sometimes shadowing if you have artifacts and so on. Let's look at these one by one. The first thing is software breakdown. You always have to look at where the segmentation lines were placed before you decide if a map is accurate or not, okay? If the software misidentifies the inner retinal layer, okay, the ILM, like this is an example. The software basically thought that this is the ILM, this is where the retina continues, and did not go down here. So what you end up here is you end up with a huge area of thickening, okay, which translates on the map, you know, as white or red, you know, like you think, whoa, this is a very thick retina. In fact, no. What happened here is the software just put the segmentation line wrongly. So you always have to, you know, look at the line scans and look at the segmentation before you judge a map, before you say, yes, there is retinal thickness or not, okay? So here you have a huge thickness, and of course, this is a wrong map. Again, same thing. You can have the segmentation line being placed incorrectly at the bottom part, you know, at the level of the RPE instead of the level of the RPE. Well, here the machine thought that the RPE is quite here, so it put the segmentation line right here. And again, you get a much higher thickness and in fact, a very, very, you know, incorrect map. This is an eye that has, you know, a CNV and that has, you know, some exudates, and instead of following the Brooks membrane down here, the machine thought that the, you know, RPE stops right there where there are intraretinal exudates. So it's completely wrong. Here in this top part, you know, the segmentation should have been placed at this level, and the bottom part, the segmentation should have been placed at this level to give you a correct map. So how do you correct improper segmentation? Well, you can do that on the machine by moving the lines one by one, you know, to their correct places. Sometimes the new OCT machines can do that automatically as well, okay? But just be careful before you interpret the map is that the segmentation was done correctly, okay? Right. Now, misalignment is when the fovea is not aligned, with the map's center. Okay, so for instance, when you have a person that doesn't fixate very well, and then basically you get the fovea off center, and you have an area of thinning, off center instead of on center. So this, how do you correct that? Here, for instance, you have, this is the map was taken up here, and instead of the fovea being at the center of the map being down here, no, it was taken up here. So you have missing data. Okay, and in this case, what you do, here's another example. Here's another example in which the fovea, which is the thinnest part of the retina, okay, is on the side. The center of the map should have been moved this way. It should have been moved temporally so that you get the proper thickness. Here the thickness is 307, but if we move the map a little bit, towards the right, towards the temporal part, and put it right where the fovea is, I'm sure that this will be a normal thickness, okay, not 307. So you have to know how to identify it by looking at a map and looking at what makes sense and what doesn't make sense, and eventually move the map a little bit towards your area of interest. Okay. Blink artifacts will look like this. If a patient is blinking, okay, then the machine is not going to generate any data. It's not going to be able to computate anything because there's no segmentation or nothing. So just going to give you a 0 value, okay? And this will look as missing data right there, missing data, okay? So these are completely inaccurate. The map is inaccurate. You really cannot rely on this. You're going to have to redo the scanning, okay? Motion is detected when you have these irregular lines. Okay, there's very little pathology, or it is inconceivable that you have pathology in the retina that has these lines. You've got thickness and then followed by non-thickness, and then thickness followed by non-thickness. This is incorrect. Okay, so when you have these horizontal lines, this tells you that there was motion. Okay, and then again, the map is going to be irregular and not interpretable. Here it is. Okay, so you can detect motion this way. You know that you cannot interpret the map correctly. Mirror artifacts happens when you have, for instance, concavities in the retina, or convexities. If you have, for instance, a choroidal or a retinal tumor that bulges forward, or if you have a myopia, for instance, in which the posterior pole is really, bowing backwards, a staphyloma, then the focusing on the retina may not be accurate, and then you're going to get, image fundus, inverted images. Because of that. Okay, this happens, for instance, here. This is a case of myopia that was not, where the focus was not properly placed, and you're going to see an inverted image of the Brooks membrane and the choroid right there. Okay, this is a mirror artifact. Here again, this is another mirror artifact. See, this is, for instance, this is supposed to be here, the mirror of this area. Okay, so you have to recognize them. This is here, for instance, you have a tumor, and the placement of the scan of the light was not placed properly on the tumor itself. It was placed on the retina, so you got this mirror image. But if you rescan with focusing on the tumor itself rather on the retina, then you can recognize the tumor itself and the proper RPE and retina on top of it. Okay, out of range is like when you get images such as this. This is an operator who didn't know how to take an image properly. Okay, then you have a whole retinal section that is just not present, and you're going to have missing data. Okay, so you cannot also generate a proper map or interpret a proper map this way. And finally, so this, how do you correct it? Well, you have to rescan. Okay, there's no way around this. But also low signal. If you have like a very small pupil, if you have cataract, you're going to have a poor quality image, and the map that the computer is going to generate is not going to be reliable. All right. If you have floaters, for instance. This is a floater. It's going to attenuate the image throughout the entirety of the image. Okay. Here you can see it on the SLO. How do you know if you have a floater or not? For instance, if you image two eyes and you've got this shadowing that is the same kind of shadowing that happens on every image, right eye and left eye, all of them, have the shadow at the same place, that you're dealing with a floater or a cataract or something that blocks the image. Okay. So basically debris on the lens even of the OCT can give you these floaters and the shadows that are in the same spot in different eyes. Okay, so we're going to go to the qualitative interpretation, and I need to know by now if you have any questions so far, because this is where it's going to get very interesting and where you have to be super alert. Do you guys have any questions? Are you there? Somebody said no, clear, doctor. Okay, clear. Okay. All right, fair enough. Well, I'm glad that it's clear. You need to know that, you know, I'm here for you. So this is the good time to ask questions. There's no problem with that at all. Okay. So I'd rather have you go out of this lecture really grasping everything. Okay. So qualitative OCT interpretation is much more interesting than just looking at, you know, thicknesses and volumes based on maps. Okay. What we do is we look at the scans, the line scans and the volume scans, every little line scan one by one, and we try to evaluate the structure, okay, of the retina, all the layers of the retina, because then we understand the pathology much better. So basically, it evaluates the structural changes, not just the thickness, and it depicts the changes of the retinal pathology, you know, over time, okay, if things are getting better or worse. And it aids in treatment decisions. And of course, when you show a patient like this, you know, the images, the patient is much more able to understand what's going on. So it's very educational for the patients. In order to know how to qualitatively interpret the, you know, an OCT of the macula, we need to know the anatomy. Okay, and so basically we call this part of the retina the inner retina. Okay, and we call this part of the retina the outer retina. And the inner retina, if you remember your anatomy, is irrigated or, you know, receives its blood supply from the retinal circulation. Okay, and the outer retina receives its blood supply from the choroid, you know, through the ciliary. Through the ciliary vessels, through the choriocapillaries, and the choriocapillaries gives you know, nourishment to the choriocapillaries itself, to the RPE, okay, to the photoreceptors. The photoreceptors being the outer retina, okay, and then at one point there is kind of a, you know, watershed zone between the inner retina and the outer retina, where the inner retina starts to be irrigated by the retinal vessels, by the central retinal artery and vein. All right, so you've got inner retina and outer retina. Now let's see how this works on an OCT. And here I juxtaposed basically a histologic slide of the macula. And how do you know that I'm dealing with a macula? Well, I think the residents who listened to the course of anatomy not a long time ago remember that you can tell if the retina, if the slide I'm taking is from the macula or not by looking at the number of ganglion cells, okay? If you have more than one layer of ganglion cells, you know that you are in the macula, okay? So I know just by looking at this that I'm in the macular region, all right? Okay, now, the inner retina, how does it look on an OCT? The nerve fiber layer is hyper-reflective. That means it's going to be bright, okay? Hyper-reflective. All the fibrous layers, that means all the axons and the dendrites and how they interact with each other, that is going to be hyper-reflective. And all the layers of nuclei, okay, whether it's ganglion cell layer or whether it's the inner nuclear layer or the outer nuclear layer, which is the layer where the photoreceptors nuclei are housed, these areas are hyporeflective. They are going to appear dark. So let's look at this one by one. From inner to outer, you have the nerve fiber layer, okay, which is the axons. This layer represents the axons of the ganglion cells. And here is the nerve fiber layer right there. And then you've got the ganglion cell here. Here it is, the ganglion cell layer right there. It is hyporeflective. It's darker. It's right there. And if you look at it, it's right there. Okay, then you've got the inner plexiform layer, which is the junction between the axons of the bipolar cells and the other cells in that layer, but also and the dendrites of the ganglion cells. So this is a plexiform layer. It is a fibrous layer, therefore it is hyper-reflective. It's going to look like a whitish band. Okay, it's right there. Here it is. There it is. And then you've got the inner nuclear layer. And if you remember correctly, the inner nuclear layer is the layer that has, right there, the inner nuclear layer. The inner nuclear layer is the nuclei, the layer where all the nuclei except the nuclei of the ganglion cell layers and the photoreceptors are. So you've got the bipolar cells, you've got the amacrine cells, you've got the horizontal cells, you've got the Muller cells. All these cells have their nuclei in the inner nuclear layer, and it is right there, okay, hyporeflective. And then you've got the outer plexiform layer, again, plexiform, therefore hyper-reflective, right there, okay? And here is the outer plexiform layer, right there. And if you notice here, the outer plexiform layer has two layers, in fact. It has this layer, which is a true plexiform layer, and then it has this layer, which is only the axons of the photoreceptors, okay? Now let's look at the outer nuclear layer. The outer nuclear layer is the layer of all the nuclei of the photoreceptors, right there. That it's hyporeflective. And then you've got what we call the external limiting membrane. It's a very, very thin membrane, okay? Very thin membrane right there, okay? Which is right there, this little line right there, okay? External limiting membrane. Then you've got the ellipsoid zone, which is a hyperreflective, quite impressive layer, hyperreflective layer, which is right there. This corresponds to the junction or the suprajunction of all these mitochondria, that are in the inner segment, okay? So that's called the ellipsoid zone, which is the inner segment, part of the inner segment of the photoreceptors. And then you've got the interdigitation zone, which is at the apex of the RPE, which is right there. The apex of the RPE, which is right there here. Remember, the RPE has all these velocities, okay, all these holes in it, and the apex, and then the photoreceptors interdigitate into the apex of the RPE by this interdigitation zone. So it's the communication, it's the junction, if you wish, between the photoreceptors and the apex of the RPE. That's an interdigitation zone at the top of the RPE. And then you've got the RPE Brooks membrane complex, which is right there, the inferior part, which is the basal lamina. Right there, it is very hyperreflective. It is the most hyperreflective line that you will see, and it is right there at the basal part of the RPE, okay? So again, because this area could be tricky, here is a bigger, way of seeing this. This is the external limiting membrane, right there. This is a rod, this is a cone. You've got the nuclei, okay? This is going to be here, the outer nuclear layer, okay? And then you've got the external limiting membrane, which is hyperreflective. And then you have this is where, the myoids are. And then here you've got the ellipsoid zone, the EZ, where all the mitochondria are. And then here you've got the interdigitation zone, where the cones and the rods go inside the RPE, right there. And then you've got the Brooks membrane complex, RPE Brooks membrane complex at the basal level. So here it is again. Now, in addition, you've got the choriocapillaries, okay? Choriocapillaries, which you don't see, and you don't actually see the Brooks membrane on the RPE, because when the RPE is hyperreflective and sitting on the Brooks membrane is so thin that you can't really identify it. You only identify it when the RPE is elevated, if you have an RPE detachment. But just beneath the Brooks membrane is the choriocapillaries, which is a very, 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 very thin, dark line, hyperreflective line. Okay, this is the choriocapillaries. And then you've got the medium-sized choroidal vessels, which we call the Sattler layer. And then you've got the larger choroidal vessels, which we call the Haller layer. Okay, and here you have the chorioscleral junction, the junction between the choroid and the sclera. So what you need to remember is that in order to be able to read the OCT correctly, you have to know, the reflectivity of all these structures, okay, and how they are normally, and what would happen when we deviate from normal, okay? So higher reflectivity, what gives higher reflectivity? The nerve fiber layer, okay? The RPE, we said that before, any scar, any lipid, any blood, okay, vessels, pigment, choroid under geographic atrophy is going to be pretty higher reflective. Okay, moderate reflectivity is when you have vitreous membranes, or for instance, the ellipsoid zone. Lower reflectivity when you have, some vitreous debris, or the nuclei, the nuclear layers, and very low reflectivity, almost no reflectivity is when you have vitreous, clear vitreous, or fluid under the retina or the RPE. Okay, so, and the rules is that if you have pigment, or blood, or fibrosis, or lipid, anything that is in the way of light, the light comes from here, goes across the retina. Anything that is stationed here, in the path of the light is going to create a shadow behind it. You're going to create shadowing behind it. And conversely, If you have atrophy of tissues, for instance, here you have an atrophy of the RPE, then the light is going to go more strongly in the back. And it's going to shine more strongly in the back. You're going to have reverse shadowing. Okay, this is a reverse shadowing. Here you have a scar, you have an atrophy of the outer retina and the RPE. The light goes much more strongly here. It's going to shine very strongly here. Like when you have a curtain, you have a hole in the curtain, the light is going to go through. Okay, that's the layers here are not going to prevent the light from going through. So you have reverse shadowing. And what are the important notes that you remember? Is that the ILM, okay, on top of the nerve fiber layer is not seen except if it's thickened, okay, or wrinkled. That again, I say it again, the Brooks membrane and the choriocapillaries, you cannot really identify them from the RPE at all, because the RPE is so hyperreflective that you cannot see them. You only see them when the RPE detaches itself. Okay, this area here under the fovea, it's an ellipsoid zone elevation. It's called clevis inversus. This is normal. It depends on the anatomy of the retina. This is a normal anatomical variation. And the Henle fiber layer, okay, the reflectivity of the Henle fiber layer, which is the inner part of the outer plexiform layer, the reflectivity, how bright it is, how white it is, if you wish, is going to depend on how the OCT was taken. If it's taken head on, it's going to appear, rather, hyperreflective and equal on all sides. But if the eye moves or if the OCT is taken a little bit sideways, then it's going to look a little bit thicker. Okay, so that depends on how you see it, depends on how the thing was taken. So any change in the outer retinal band's reflectivity indicates that the structure is either damaged or misaligned. Okay, now there is a question in the chat, I think. Laser marks will cause reverse shadowing. Yes, laser marks will continue. Yes, laser marks are chorioretinal atrophies. When you burn the retina, you create a chorioretinal scar. You create an adhesion of the retina, of the inner retina to the outer choroid. Okay, and therefore you lose the RPE and you lose the outer retina and you lose the choriocapillaries, and you create an adhesion between the inner retina and the middle and middle choroidal layers. So yes, it's going to be an atrophic tissue. Therefore, it's going to cause reverse shadowing. Okay, now a word about image orientation. If I show you an image just like this, okay, and I tell you which side is nasal, okay, I don't know if anybody wants to answer, but I'm afraid that if we do this interactively, we may lose a lot of time. Well, somebody answered, which is good. The right one. Which side is nasal? The right one. Okay, I suppose the right one is this one. And why? You're correct. This side is nasal, and why is it nasal? Is because we are seeing a thicker nerve fiber layer here than here. Okay, this is the clue that you have a thicker nerve fiber layer. You know that the ganglion cells basically give up axons, and the axons all go into nerve fiber layers that go to the optic nerve. So the closer you are to the optic nerve, the thicker the nerve fiber layer is. So yes, this is this area is nasal. Okay, and here, where is the head of the arrow on the OCT line scan? I'm showing you this, okay, and I'm showing you an arrow. So where is the head of the arrow on this part of the scan? And I think we've been through this. Well, basically, as by convention, as we mentioned, the arrow is always on the right. So the arrow is here, okay? And this will be the base of the arrow. This will be the head of the arrow. And therefore, this is inferotemporal, okay? And this is here supranasal. And in fact, you can corroborate that it's supranasal because, again, you have a nerve fiber layer that is thicker on this side than here. So this is definitely nasal. This is supranasal going downwards. This is a scan of the retina in this direction. And this is the head of the arrow, and this is inferotemporal, okay? And this is here a scar with an atrophy of the RPE and the outer retina, in which you can see reverse shadowing. Same thing here, actually, okay? Now, which side is nasal here? Can anybody tell me? No, nobody wants to tell me which side is nasal? Okay. Yes, it is a vertical scan. That is correct. It is a vertical scan because the nerve fiber layer is equal on both sides. Okay. Another clue that tells you that this is a vertical scan is the presence of the vessels. Okay. And if we look here, we see that the arrow goes up. Therefore, this is superior. And, this basically the arrow is up. So this is superior. Okay. And remember, the head of the arrow always points to the right. So this part is superior and this part is inferior. Correct. What are these? I think you guys know this. These are the vessels that go through the retina, and each vessel basically blocks the transmission of light, so it creates, you know, reverse shadowing. These are vessels, retinal vessels that create, you know, shadowing. Sorry, I'm shadowing, not reverse shadowing. These are retinal vessels. Here again, this is a PVD, and that, you know, the vitreous is detached from the retina, and here are again vessels that you see, you know, that are creating shadowing. And here we can follow them. This vessel here, for instance, is this one here. Okay, this vessel here is this one, and this one you can see that it's kind of, you know, broad, and that's because the line went through the vessel, you know, tangentially. So it's not going, it's not cutting the vessel, you know, right straight on, but it's actually going throughout the vessel as the vessel is, you know, horizontally oriented. So you can see the broader line and a broader shadow. Okay, so these are typical bloodshed. What are these? What is this? And anybody answer? What's this thing here? No answer. Okay, somebody wrote blood vessel. Yes, in fact, this is a blood vessel with the posterior shadowing, equal everywhere. Here is the line that went exactly where the blood vessel was lying, and here you have, you know, the shadowing, the blood vessel and the shadowing. So when you see this, you cannot say that there's an atrophy or loss of tissue. No, this is actually just shadowing. Horizontal. This is a horizontally oriented blood vessel. And what are these? What are these here? What would this be? Okay, I'm waiting for your answers because this is fun. When you guys answer, I know that you're awake, okay, and that you're trying to understand this, which is, okay, it's a choroidal vessel. Yeah, absolutely. This is a choroidal vessel. This is a choroidal vessel. It's right there. You know, the choroid is really, really thin here. Look, you see the sclera. Okay, this is the sclera, hyperreflective sclera with no vessels whatsoever. But here you have a large, you know, choroidal vessels, like a polyp almost, you know, not a polyp, but like a macro vessel here that went and pushed the retina forward. Okay, so that's a choroidal vessel. Perfect. Okay, the choroid, what is this layer? The layer is thin. How is the choroid? The choroid is thin. Okay, and what are these? Again, this you can see posterior shadowing. A lot of posterior shadowing. You can see the RPE layer, you can see the ellipsoid zone, and then basically this is all lost, and you have tremendous, you know, inverse shadowing behind it, and that's because you are going through a series of, somebody answer, chorioretinal atrophy. Yeah, exactly. This is chorioretinal atrophy, and the reason there was chorioretinal atrophy is because there were big laser scars. Okay, so big laser scars here, you know, that caused this this shadowing, inverse shadowing. All right, so what are these now? What are these? Can anybody tell me what this is? Pigment epithelial detachment, correct. And drusen is correct. RPE detachment is correct. Absolutely. And it's very easy. You just follow the hyperreflective line, which is the RPE Brooks membrane, and you see that it goes up, you know, like a little hill. Okay, and so on, and it goes up, and again it just goes up. Okay, and when it goes up and it detaches itself from the Brooks membrane, that's when you see this little tiny thin white line or hyperreflective line, which corresponds to the Brooks membrane. Okay, so this is drusen. Okay, and drusen is basically a small PED, small pigment epithelial detachment, and when it's bigger, you know, we call it PED, but that's a drusen. Here, for instance, you have the Brooks membrane, as I showed you. Here above the RPE, this is what we call pseudodrusen. These are what we call subretinal drusenoid deposits. So these are not drusen. These are, you know, little excrescences on the top of the RPE, between the RPE and the ellipsoid zone, and that's called pseudodrusen. Okay. Now, what is this one? I'll put this here. Okay. What is this one here? What is elevated? Yes, this is subretinal fluid. Yeah, subretinal fluid. So what's elevated? So the RPE is intact, okay, but it's the ellipsoid zone that kind of went up and down here, and so you've got, you know, a simple fluid, a hyporeflective cavity on top of the RPE. There's a question, doctor, can you show us how it's above the RPE, the previous image? Okay, sure. Here it is. Okay, you see the RPE? You see the RPE right there, and then you've got something on top of it. You see the RPE, and you've got something on top of it. Okay, here also you've got something on top of the RPE. These little excrescences. So these are subretinal drusenoid deposits, and this is a neurosensory retinal detachment. Okay, All right, good. Yes, clear. Very good. Okay, so this is a subretinal detachment. And what are these? So I'm going to go little by little. You know, what are these? Write this. What is this? This is CNVM. I don't think you should say CNVM. It's a good thought. I think, wait, how do I get away from this now? Yeah, hold on. I'm getting confused. How do you do this? Okay, right. So I think you're saying CNVM because you're seeing blood, but I'm asking you on an OCT. Yeah, well, it is a pigmented field detachment or a drusen, if you wish. Okay, this is a drusen right there. And write this here. This is a pigmented field detachment. So see how you can see the Brooks membrane right there. You see this white line? It's right there. So the RPE is elevated. It's a dome shape. This is a pigmented field detachment or drusen. But here the RPE is corrugated and elevated from the Brooks membrane. Okay, so what we call a double layer sign. Okay, and here we can see this thin black line. That's the choriocapillaries. Okay, and then here this thin white line or bright line is the Brooks membrane. And what do you see here is an elevation of the retina. So the RPE is intact, but the retina itself is elevated. If you follow the ellipsoid zone, you follow it, it goes up, 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 and then comes down. And basically you've got hyperreflective subretinal fluid, which in this case is blood. Okay, and the shadowing of blood in general is very gradual. Okay, notice how hyperreflective it is here, and then it fans down directly. Yeah, there is a thin choroid. Exactly. The reason it's a thin choroid because this patient had, I think, AMD or possibly, age-related choroidal atrophy. You're right. There is a thin choroid. Okay, so gradual shadowing. So what is this? Basically, I'm saying this is posterior vitreous. Yeah, and you've got here thinning of the retina. You've got thinning of the retina compared to here. This is the nerve fiber layer. Okay, and this area is thin. The whole area is thin. Why is that thin? Possibly because there was like an ischemic onset to the retina. Okay, now let's look at the vitreal and the vitreoretinal interface pathologies. We're gonna look at some examples of all the pathologies that you can find and how we interpret them. Okay, so one of the first thing that the easiest thing that you can see is when you have these hyperreflective dots, okay, and structures inside the vitreous. And here they are. Okay, when you have something this big, generally it is these are floaters. Basically, they're not cells. Cells are rarely this big. Cells are usually much smaller, but the ones that are here, are going to appear and they're going to shadow. Okay, they're going to see this. There is a shadow of each of these structures, and this right there, and it's shadowing. And maybe there's another one up here that we don't see that is shadowing, and so on and so forth. And because of this shadowing, you're going to see, because of the hyperreflective, you're going to see shadowing. And sometimes what happens is because they are taken by the image, which was centered on let me put it this way: the operator basically tried to take an image on the retina, focused on the retina, which is what we should do. But because these images are far anterior to the retina, okay, they're going to be captured. The mirror image of these structures are going to be captured posteriorly. Okay, so what happens is sometimes you get a mirror image of these structures inferiorly. This doesn't mean that there's asteroid hyalosis at the level of the choroid. Okay, these are mirror images of the vitreous images. Okay, mirror. Okay, because they're out of focus. The focus on these. The retina is the plane of focus, and basically everything that's anterior to it is going to appear in a mirror fashion inferior to the retina. Okay, so that's how you interpret it. Now, what would this be? You've got here the posterior vitreous phase, which is elevated but still stuck to the fovea. Okay, there is no distortion of the retinal architecture. You can see that the layers have a nice, stratification to them. Okay, this is not pathologic and usually is asymptomatic. What do we call this? This is very common. We see it. It's part of aging. What do we call this? What do we call when you have the vitreous attached to the retina? VMA. Yes, this is a vitreomacular adhesion, which is within the process of a posterior vitreous attachment. When a vitreous attachment happens, PVD happens, it goes into stages. And at one point, the vitreous is detached posteriorly, but still is attached to the retina, at the fovea or at the optic nerve, and you get this VMA. And it can, of course, detach completely and leave the patient, asymptomatic with no problem. So that's a VMA, okay? So you have an incomplete vitreous detachment, okay? Because the vitreous is still attached to the fovea. All right, now, what if I show you this thing? Is this a VMA? Somebody said VMT. Why do you say VMT? You say VMT because this is being pulled a little bit? Traction? Okay, well, maybe this is not enough to really consider this VMT, because you see that the contour of the fovea is really nice. And if I show you the inferior scan, okay, the inferior part of the macula, you see that the vitreous is detached and really did not leave, much distortion, but maybe there's a little bit of a cyst at the bottom part, at the inferior part of the macula. But what causes you to say VMT is the fact that when you do more lines, so when you look at more lines, you're going to see that in fact there is indeed, some traction. There is distortion here at the level of the fovea. So this is the superior part of the macula. This is the inferior part of the macula. In both cases, the vitreous is attached. Here, you were lucky enough to see a little bit of traction. So I would say, yes, okay, this is VMT, but really when you look at the line just inferior to it, you're going to see that there is, yes, significant traction, and there is a cystoid change. So yes, this is this is not VMA, this is VMT, it's the same eye. So the message and the lesson from this is, when you have a scan, please look at every single line, okay? Because otherwise you may miss it. If you just look at this or just look at this, say, oh, no, this is VMA, this is complete PVD, we have nothing, there's nothing going on. No, please look at every single line, okay? Look at all slides. Now, what is this hyperreflective structure, at the inner retinal surface? I'm sure that most of you know this. This is what we call an epiretinal membrane, which is a glial proliferation on top of the coming from the Muller cells, basically, that's laying down collagen on top of the retina and causes sometimes wrinkling of the retina, what we call macular pucker. And now the wrinkling can happen like this, can distort the retina. It can sometimes, can basically pull the retina in this direction, creating what we call a pseudomacular hole. Okay, this is not a macular hole. All the structures are intact. You can see the retinal stratification is correct. There is no loss of tissue, but the fovea basically, has a very steep line, and almost we think that this is a hole, but it actually is a pseudomacular hole, because the epiretinal membrane is pulling, the retina centripetally towards the center. Or sometimes the epiretinal membrane can be associated with macular hole, where you can have really loss of structures. This here, you've got some loss of tissue. This is not a full thickness hole. This is an inner lamellar hole, because you can see that the outer retina is intact. Okay. Okay. What is this? What is this thing? Does anybody know what this thing is? Where's the pathology here? No clue? Okay, somebody. Epiretinal hemorrhage, yeah, exactly. This is an epiretinal hemorrhage. Basically a hyperreflective area or subhyaloid, okay, or maybe a sub-ILM hemorrhage rather, okay, which is basically blood trapped in between the retina and the ILM, and basically it shadows posteriorly, and you can see that's, it probably is associated with some blood in the vitreous as well, okay, and it causes a lot of shadowing. Here it is. This is a diabetic patient. This line was taken about here, and this is a sub-ILM hemorrhage right there, okay? So, so this is very clear. Now, what is this thing? Oops, sorry, what did I do? Yeah, okay, all right. So you can have epiretinal membranes in vascular diseases and inflammations, after surgery, etc. Let's look at this eye, okay? And the question is there a traction retinal detachment? Where and which eye? So this is the same patient. This is the left eye, okay? And if you do an OCT, you're going to see this structure. So I'm asking here whether there is a traction retinal detachment, yes or no? In this top image, is there a traction detachment? Okay, maybe this is too difficult. I don't know. I'm not seeing anybody answering. But basically, oh, okay, there are some answers. Somebody says yes, and another person says not, and other one says schisis, not detachment. Okay, more or less correct. Basically, what you see here, this is an epiretinal membrane. This is the posterior vitreous, and this is the epiretinal membrane that's pulling on the retina. This is where the fovea is supposed to be, and it has created a partial thickness macular hole and a lot of elevation, okay? Elevation here with subretinal fluid. Notice that you have got pockets of subretinal fluid right there, but the retina is attached. At every level, the retina is attached. It is thickened here. It has debris, probably hard yellow exudates, or even blood. It's, irregular. And it is causing so much stretching of the retina that you get these schises-like cavities. I don't know if you can see them very clearly, but the retina is attached, okay, except here where there is a little bit of subretinal fluid. Therefore, in this area, it is detached. In this area, there is a detachment. There is a very focal detachment of the retina because you have subretinal fluid, correct? And you have an inner lamellar hole. So yes, there is an epiretinal membrane and there is a TRD right there. How about the other eye? The other eye, you have a fibrous proliferation from the diabetes, and you've got an epiretinal membrane, okay? And this epiretinal membrane is pulling, and it's pulling the retina off the RPE. So yes, it is detached. There is a traction detachment. It is much more obvious here than in the left eye, but both eyes have traction detachment. So what is this? Can somebody tell me what this is? Okay, well, just because of time limitations, this is again a sub-ILM, collection, and this collection is shadowing posteriorly. So chances are that this is not just fluid, that this is, murky fluid such as blood. Okay, so this is a sub-ILM hemorrhage, again, with posterior shadowing. And here it is. This is following a laser injury, but of course you can have this also following a Valsalva or what have you. Okay, so this is typical of a sub-ILM hemorrhage. And what about this one here? What can this be? Does anybody know? Okay, this is a sub-ILM hemorrhage also. Here it is. All right, and there is actually, this line is not really this line. So, this was placed to fool you. Okay, this is a vertical scan. This is a vertical scan. This is, while I'm showing you here a line, a horizontal scan, but this is actually a vertical scan of this eye that went like this. Okay, and here you see the pseudo, the level, the horizontal level because of the gravity. So the subretinal blood is, moving downwards, all right? And the top part of the pocket has much more clearer fluid right there because most of the RPE cells have settled inferiorly. So this is the vertical scan corresponding to this. Again, notice the tremendous amount of shadowing and the progressive shadowing that you see. So a lot of hyperreflectivity and then progressive shadowing. And what we did here is we created a break with a YAG laser. We evacuated the blood, to permit the eye to see better. And you can see all the blood that was evacuated here, okay? And the ILM pocket is now more or less, empty, all right? So here it is. And after we've done the YAG laser, the blood went down, and basically you have, the blood is still actually going down. And here is the original pocket, and then you have the fovea is free, okay? So this ILM detachment, by the way, never really actually sticks back to the retina. We've noticed that it just stays there. Okay, so those were the interface pathologies that we encounter most commonly. Let's look now at the intraretinal pathologies. All right, so I'm showing you this, and I think you probably all recognize that this is a loss of tissue at the level of the fovea, and basically, therefore, it's a macular hole. And I'm asking you whether there is a difference between this macular hole and this macular hole. Are they both full thickness macular holes, or are they, partial thickness macular holes? I don't think you have a problem by noticing that this is a partial thickness macular hole because you have intact outer retinal structures. But if you look at this, despite the fact that this is very deep, actually you do have preservation of the external limiting membrane, a little bit of atrophy of the ellipsoid zone, but really you still have an intact, outer retina right here, outer nuclear layer, and an intact EZ. So basically there is no difference. Both of them have intact outer retina, so both of them are inner lamellar macular holes. If you look at this one, I think you have no problem saying that this is a full thickness macular hole. Okay, here it is. The retina basically stops, and there's a full cavity in between the two versants of the macular hole, and you have some cystoid changes, which is very common after a macular hole. So here it is. So that's a full thickness macular hole, but so is this one. This is also a full thickness macular hole. You don't have any continuity of the ellipsoid zone and the outer retina in either. But why is this bright? Why do you have this brightness right here? Who can tell me this? Okay, why is this bright? Can anybody tell me why this RPE here is brighter than here? Reverse shadowing, absolutely. Yep, reverse shadowing. Basically, you have the line of light here came in uninterrupted and caused, this RPE to appear very bright compared to this area where you have the retina shadowing a little bit the outer retina, the RPE. Correct, absolutely correct. Okay. It had the chance to receive the light. Yes, I like the chance that it got. Very cute, very nice. Okay, so this is right because of reverse shadowing. Here's that macular hole. This was again a blue laser injury. Okay, now let's look at this one, and I'm going to ask you to tell me where the fluid is located. Where is the fluid here? What would you call this fluid? I'm waiting for your answers. This is really fun, guys. You're answering me. This is really cute, nice. So where's the fluid here? Yeah, somebody's answering. Subratanal. Yep, subratanal fluid. Absolutely. Okay. And where is the okay, where's the fluid here? Or here? What layer? Yeah, I know. It is intraretinal, but which layer? Which layer of the retina? Follow the lines, follow the structures. Okay, follow the structures. What structure is this one? Okay, this is the OPL, right? This is the OPL, exactly. This is the OPL right there, the hyperreflective layer that kind of goes upwards, and then you have the fluid in the OPL, in the outer plexiform layer, which is where fluid tends to accumulate first in a retina, okay? And then how about this fluid right there, and this little pocket right here? What layer is this one? Where is the fluid here? Follow this line. Follow the structure, the inner nuclear layer. Absolutely, it is in the inner nuclear layer. So fluid can go from the outer plexiform towards the inner nuclear, but also towards the subretinal fluid, okay? Subretinal area. So inner nuclear layer. Very nice. Okay, I don't see what am I doing here? So yeah, what is this? I'm asking here, what is this thing? Okay, what are these structures here? What's happening here? What do you see? Do you see a continuity or no? What is missing here? Okay, let me see. So disruption of the retina, disruption of the ellipsoid zone. Absolutely. The external limiting membrane is relatively intact. Okay, you can see it, you can follow it here, but the ellipsoid zone is really disrupted. So this is an outer retinal hole. Okay, this is an inner lamellar hole. It's an outer retinal disruption, and because there's a disruption, again, the choroid has the chance to receive the light. Okay, there's less structure here. Therefore, it's letting more light go back. Very, very nice. Okay, so basically, this is an outer retinal hole due to either looking at an eclipse or the sun or a very strong light such as the blue laser. Okay, okay. Question: is this a vertical or a horizontal scan? Who can answer me? This top one, vertical or horizontal? Okay, lots of answers. Vertical, V, very nice, vertical. And the reason you know that is because you've got equal nerve fiber layer thickness. Okay, how about this one? I think you guys know this. This is a horizontal scan because you've got the nerve fiber layer that is thicker on the side. Okay, and there is another clue, which is the vessels. On a strictly horizontal scan going through the center of fixation, through the fovea, you should not be seeing any vessels because the raphe basically is that right there. Okay, there's no continuity of the blood vessels that irrigate the superior part of the retina with those that help or provide nourishment to the inferior part of the retina. Okay, so the vessels are also a clue. Okay, so vertical scan and horizontal scan. Okay, now other intraretinal pathologies that we see very, very commonly is macular edema. And the macular edema, whether it's due to diabetes or due to, Irvan gas after inflammation or, vein occlusions, they all kind of look the same. Okay, now the macular edema is basically pockets of fluid that accumulate in the outer plexiform layer, but also sometimes in the inner nuclear layer, and sometimes even with this subretinal fluid. Okay, and those pockets of fluid can be not too big, causing like a diffuse thickening of the retina, or sometimes they can really be quite big, causing big cystoid spaces, CME, or sometimes they can be associated with subretinal fluid, and sometimes they can be associated with an epiretinal membrane. So all these are variants of macular edema due to different vascular diseases. Okay, so you cannot really tell by just looking at the OCT, you know, whether this is a CRVO versus a diabetic macular edema, based on the structures that you see. All right, but however, the OCT can show you really important clues about the visual potential. Okay, now here, for instance, you have an intact outer retina, you've got an intact ellipsoid zone and an intact external limiting membrane, ellipsoid zone, and basically you have relatively good stratification of the retina. This should have relatively good prognosis, even if there are, you know, cystoid changes. However, when you start seeing that you've got atrophy of the outer retina, this portends to a poorer prognosis. Even if you get the retina to dry up with the anti-VEGF treatment, you know, chances are that there will still be some, you know, visual loss because of the outer retinal atrophy. Also, when you start seeing a loss of the normal stratification, and look how smudged everything looks. Okay, this is a disorganization of the inner retinal layers, which is what we call drill. This is also a sign that, you know, the visual potential isn't as good. Okay, now in addition, quantitatively, of course, the OCT can definitely tell you, you know, where the thickness is. For instance, here it shows you that the thickness is really way out, you know, not center involving. Okay, while in here it shows you that there is thickness all over and it is center involving. So that can help you also determine treatment. Okay, now how about when the thickness is associated, or even when you don't have thickness, when you have intraretinal hyperreflective, you know, areas. For instance, here, okay, you have hyperreflective area that shadows. You have a hyperreflective area here that also shadows. You have a hyperreflective big area here that shadows. You know, these could be, depending on the pathology, depending on the full clinical picture. This could be lipid, for instance, here associated with, you know, retinal thickness. This could be, in this case, it could be pigment. Okay, when you look at the picture, you see that there is pigment. For instance, in an eye that has, you know, juxtafoveal telangiectasia, you've got pigment, therefore it shadows. Or you can have, you know, fibrosis, like in here. This is a chronic macular edema that caused a lot of fibrosis at the retina, coming from under, going, you know, and being basically going throughout the entire thickness of the retina, huge fibrotic nodule, which you can see in diabetes, you can see in Coats disease. Anytime that you have long-standing exudation, you can have this fibrosis, and all of these shadow posteriorly. Okay, so any structure inside the retina will cause shadowing. Okay, lipid, blood, pigment, fibrosis, what have you. All right, now what you notice here, what do you guys notice? Do you notice anything weird about this retina? I'll answer that in a moment. Okay, some people. Okay, do you notice anything in particular here? What's the difference between this, if I show you this, and this? What do you notice? Okay, look at the stratification of the retina here, and look here. What do you notice? How does it look? Okay, it looks very hyper-reflective, right? It looks so hyper-reflective, so white. Okay, that this is a sign of ischemia. This is a sign of nerve fiber layer congestion, okay, exoplasmic stasis in the nerve fiber layer, in the ganglion cells, that causes so much hyperreflectivity. There is no movement of the exoplasm in the nerve fiber layer, you know, that is the you have so much hyperreflectivity that it actually shadows back. There is no subretinal fluid. The retina is intact. If you notice carefully, the retina, the outer retinal layers are really stuck to the RPE. There is no detachment. There's no subretinal fluid. All what you're seeing is extensive shadowing because the retina is so hyperreflectivity, it's blocking the light. Okay, this is what happens when you have retinal ischemia. You know, either a central retinal artery occlusion or a branch retinal artery occlusion, or sometimes even middle layer occlusions. You know, so this is a sign of infarction. So is this subretinal fluid? Actually, no. This is just posterior shadowing. And here's an example of a patient that developed central retinal artery occlusion, but did have a ciliary retinal artery that is irrigating and properly perfusing this nasal retina. And in the beginning, you know, it looked like this. It looked like hyperreflective and very thick. But once you enter the chronic stage, what happens, you know, with the infarction is that the inner retina is going to atrophy. Okay, so basically we have here a line that is, you know, taken right there. Okay, you have basically a scan, that volume scan in which a line was taken right there. right there, here it is, and what you see is an atrophy of the retina. So once you have the hyperreflectivity is gone, it's going to get replaced by an atrophy of the inner retina, such as we see here. But notice that this line, okay, this line here was taken at this level chronically, and what do you see? You see basically that the retina got atrophied in the area that was infarcted, but in the area that remained, intact with proper perfusion, the retina maintained its structure. Okay, and then when you go down here below the area of preserved, irrigation, you're going to see atrophy again. So this shows you how the atrophy after retinal arterial occlusion. And you have atrophy after hemiretinal vein occlusion and after, even CRVO. Anytime that you have, a lot of ischemia in the retina basically dies progressively. The inner retina dies progressively. All right. So where are these hyporeflective cavities? Can somebody tell me where these hyporeflective cavities are? In which layer? And is this macular edema or not? Okay, I'm waiting for the answer. This is like a game show, guys. Okay, so inner nuclear layer, absolutely. This is in the inner nuclear layer. You've got cavities, of increasing, width in the inner nuclear layer. I don't know what L is, but, I'm going to say that it is inner nuclear layer. And this is, so not very common to see macular edema without, with just an inner nuclear layer separation or cystoid cavities. Usually you have some component of outer plexiform fluid. In this case, we don't. And this is actually a retinoschisis. This is a juvenile retinoschisis where you have splits in the inner nuclear layer. And on the fluorescein, you have absolutely no leakage. Okay, it just stains a little bit. And the diagnosis that this is an X-linked schisis. But actually, every time that you have a schisis, this is what a schisis looks like. Now, here you have a patient that has juxtafoveal telangiectasia, MACTEL, okay, macular telangiectasia type 2. And in this case, this commonly you have, capillaries that stain on fluorescein, and you have loss of Müller cells, and then often you have crystals, in the retina, and sometimes in stage 4 you have pigment deposition. So here it is. This is the juxtafoveal telangiectasia. You don't see much. Okay, there's a grayish of the fovea. If you do a fluorescein, this is early on and this is late. You see a little bit of staining, and this is where the pigment is. Okay, and that's how it is. But what do you see on an OCT? You actually see loss of retina. Okay, because there's a loss of retinal of Müller cells. This is a Müller cell disease. So you don't have, or despite the fact that you have, the staining and minute leakage towards the end of the fluorescein angiogram, you don't have any thickness. On the contrary, you get atrophy. So you get atrophy and loss of tissue in the inner layer, but also in the outer layer. Okay, there is no thickening. So telangiectasia type 2 is not associated with any thickening, just, cavities. We call these cystoid cavities. That's what we call them. And when there is loss of tissue and you only have an ILM remaining, we call that an ILM drape. Okay, so anyway, so here, I don't know what was I asking? I don't remember. So, okay, I ask, what is this? Okay, and basically, yeah. So what do you see? You see basically atrophy, right? You see atrophy compared to here. This retina, this whole retina is atrophic, but also the outer retina is atrophic. And by consequence, you start to see the choroid, being much more hyperreflective than here. So basically, this is an inner retinal atrophy with loss of stratification called drill, and you have posterior inverse shadowing. Okay, so this is like, this was after a BRVO. I'm asking whether this is a horizontal or a vertical. I think you guys know this, that this is here. You've got inner retinal atrophy here, and you don't see any blood. Well, I do see a blood vessels, yes, right there. So this is a vertical scan. Okay, what is possible diagnosis here? We said that because of the atrophy on this side compared to here, that this is a sectoral atrophy. And if you look at the picture, you need to, of course, always look at the picture or do a fundus examination to see where you're looking at. In this case, it was a hemiretinal vein occlusion. We talked about this earlier. Okay, so when you have like laser scars, or burns, basically you have atrophy of the outer retina and of the inner choroid and the choriocapillaries, and therefore this line went right through there, through the scar, and gives you tremendous shadowing. So notice that you have the RPE, and then the RPE kind of disappears. The ellipsoid zone also disappears, and basically you have lots of inverse shadowing through all these lesions. This is this big scar right here. And if you look a little carefully, this is this area, and this area would be this area right there. Okay, so very nice. Anyway, yeah, all right. So another thing that can happen in the retina when you have outer retinal atrophy is when you have degenerations. For instance, this patient has tremendous amount of RPE atrophy and outer retinal atrophy. Look how thin everything is and how disrupted everything is. And you've got this tremendous shadowing, you know, of the vessels and of the choroid. So this, in this case, you have basically a very thin choroid in which even the vessels tend to shadow. And this is a case of, you know, cone rod dystrophy, rod cone dystrophy, you know. Here's another case of, you know, retinitis pigmentosa with the autofluorescence showing the hyperautofluorescent ring with the tunnel field that's very restricted. And if you do an OCT, you see that under the fovea, you still have a nice outer retina. This could be compatible with 20/20 vision, but of course the visual function is very, very bad because of the field is very small. So these people have tunnel fields. They may have 20/20 vision until some stages in their disease. But if you look elsewhere, okay, there is atrophy of the outer retina. Notice here that you have the outer nuclear layer, but when you come in here, you hardly see anything. Okay, you have an external. Well, not even. You've got an RPE, which is more or less intact, but then the ellipsoid zone is gone. Okay, and you've got here the inner nuclear layer. So again, here, this is another case of cone dystrophy in which you have atrophy of the outer retina, shows very, very clearly right there. Okay, now plaquenil toxicity also gives you outer retinal atrophy. Right here, it looks like a saucer shape, like a spaceship. Okay, so the outer retinal atrophy often starts around the fovea and giving you these this reverse shadowing. What are these now? Okay, there was a question earlier on. So in the retina, sometimes you see these hyperreflective spaces that have a very distinct, you know, hyperreflective ring. These are rosettes that form when the retina, the outer retina is really degenerating and very sick. So the retina starts to form these rosettes, and we call these outer retinal tubulations. Yep, outer retinal tubulations is what they are. This is a sign of you know, retina being really sick and advanced and in advanced disease. Okay, you can see this in retinal degenerations. You can see this in CNVs. You know, when the choroidal neovascular membranes on the outer retina is really sick, you see these outer retinal tubulations. Okay, now let's look at the subretinal pathologies. We've finished the retinal pathologies. Look at let's see some subretinal pathologies. I think we all know what this is, right? What is this? This is a serous PED, absolutely. Yeah, serous PED, you can follow. This is a beautiful scan, by the way, guys. I mean, if you see this, the 4 lines here, you've got the external limiting membrane, okay, the ellipsoid zone, the interdigitation zone, and then you've got the RPE right there, the hyperreflective, very bright structure. And you see when you follow the RPE, whoops, it goes up and down like a hill, and you've got, you know, hyperreflective fluid under it. This is a serous PED. Okay, this is not a fibrous PED or fibrovascular PED or a drusenoid PED that has all the junk. No, this is a PED that has just clear fluid under it. So this could be part of CSCR, for instance. Okay, so this is typical of a CSCR. And what is this? I think I've shown you this before. This here, no, you've got the RPE that is pretty intact. Maybe it has some debris on it. But then when you look at the ellipsoid zone, okay, the ellipsoid zone actually goes up and down, and you've got clear fluid here. This is a neurosensory retinal detachment. Okay, again, in this case, probably due to you know, central serous chorioretinopathy or polypoidal vasculopathy, what have you. Any case of exudation can give you this feature. Okay, even inflammations. And here's an example of a patient who had chronic central serous, well, actually not chronic. She had central serous chorioretinopathy. Here's the pocket of fluid. Right there, you can see it on the SLO image. It is right there. And here was the leaking spot, you know, that gave the ink blot appearance, okay? And when you do an OCT, right here, you know, throughout the middle, you're seeing actually the subretinal fluid, you know, reaching the fovea right there. But if you do a vertical scan or a kind of a radial scan, you see that the subretinal fluid is much more elevated, you know, superiorly than inferiorly. In the inferior retina, she has no detachment whatsoever. The detachment reached the fovea and just detached the fovea. Okay, and remember when I told you where do you see the arrow? The arrow goes down. Well, maybe in this case it's not very clear, but the arrow is the ones here. So this is the right part. This is the right part of the frame. The right part is therefore the inferior part, okay, and this is the superior part. So the OCT can definitely localize the area of the subretinal fluid, and you can tell that although the fovea is thinly detached, much of the fluid is actually in the superior part. Okay. So what are these, what are these, what is elevated? We've seen this before. What is elevated here is the pigment epithelium, okay? The pigment epithelium, you can follow it. Here it is, a very hyperreflective, zigzaggy appearance of the pigment epithelium. This is pigment epithelial detachment. And when they're tiny and small like this is called drusen. Okay, and this is the Brooks membrane, the very clear, I don't know if it's very, on Zoom, maybe you guys don't see it very well, but there's a very, very thin, white line, that's the Brooks membrane. So this is a case of AMD, with large drusen, these are deposits under the RPE, all right? The deposit, the hyperreflective material is under the RPE and of course above Brooks membrane, okay? And what is this here? This is an area of atrophy. The RPE is really atrophic right here, and therefore causing the inverse shadowing. Okay, and the RPE is so atrophic that you have no RPE to suck the fluid from inside the retina, and that's why you have the intraretinal fluid right there. Okay, so remember these things is that when you have a serous PED, okay, you have hyporeflective fluid, but when you have drusen, okay, the pigment epithelial detachment will have, hyperreflective or moderately reflective material or fluid under it, okay? So this is not a serous PED, but this is definitely a serous PED, all right? Now, again, where was the question? What was the question? Okay, I don't know what I was saying, but anyway, these are deposits on top of the pigment epithelial detachment. We spoke about this in the beginning of the lecture. These are called subretinal drusenoid deposits or pseudodrusen. They're not drusen because drusen are deposits under the RPE, between the RPE and the Brooks membrane. These are on top of the RPE. These are called subretinal drusenoid deposits, and these are actually a sign of high risk for developing choroidal neovascularization, okay? This is the RPE right there. If we follow it very carefully, you'll find that it actually elevates, and then it elevates again, and then you see this thin line, which is the Brooks membrane. So these are drusen, okay? While here, these are on top of RPE. These are pseudodrusen. And here, the RPE is intact, but what's elevated is the ellipsoid zone, and you've got, subretinal fluid with some hyperreflectivity because of the conicity of the fluid here. This is neurosensory retinal detachment. So here, this is drusen, okay? So deposits under the RPE and above the Brooks membrane, all right? These are pseudodrusen, the ones I'm showing you here. All right, and these are subretinal drusenoid deposits above the RPE and under the neurosensory retina, okay? And here, this is subretinal fluid. That's a little murky, so it's kind of a vitelliform lesion. We call it vitelliform. Every time that you have subretinal fluid that starts to become yellow, we call that vitelliform, like an egg yolk, okay? All right, so now you also have vitelliform macular dystrophy, Best disease, which is, again, a collection of fluid between the RPE and the neurosensory retina. It is not an elevation of the RPE. It is between the neurosensory retina and the RPE, and it's yellow because you have a lot of fluorophores in that area that are unable to be phagocytosed by the RPE. So at the vitelliform stage, you can see that there's hyperreflectivity that shadows back, okay, that doesn't give the chance of the choroid to get all that light. I love that experience, what the resident said earlier. So yeah, and then you have a pseudohypopian stage. Here it is, okay. And if you do an OCT and you know that this is a vertical scan, you can see that the hyperreflective material is inferior, okay, and the not so hyperreflective material up there in the pocket of fluid is right here, okay. So basically what I'm trying to tell you here is that any chronic exudation, okay, whether it's due to CSR or whether it's due to, inflammation or Best vitelliform dystrophy or even AMD, anytime that you have a subretinal fluid that stays too long, it doesn't become, hyporeflective anymore. It starts to become hyperreflective because fluorophores from the discs of the photoreceptors accumulate in that area and the RPE is unable to cope. And therefore you have, a lot of, hyperreflective, fluid in that area. Okay, so acutely, a central serous choroidal retinopathy is going to have subretinal fluid that is, serous, but chronically, neurosensory retinal detachment in CSCR or any other neurosensory retinal detachment that exists too long, it's going to have hyperreflective material. Okay, so remember that. Now, if you have subretinal blood, okay, subretinal blood is going to show an again hyperreflectivity. Okay, but it tends to shadow progressively. Look at the difference between this one, where you have fluorophores. It tends to be it doesn't shadow much, but it's really like quite yellow, and it gives this appearance, this hyperreflectivity without much shadowing behind. There is some shadowing. I mean, look here, you do have some shadowing, but it's not too much. While when you have blood, it is much more compact. It doesn't really give the chance of the choroid to get all that fluid, or get all that light. So you have a tremendous shadowing in the back. It gives you this progressive shadowing. Okay, now let's look at how CNV, choroidal neovascularization, looks on an OCT. Now, as you know, there are several types of choroidal neovascularization. There's the one that grows from the choroid capillaries through the RPE and under the retina. You have the growth of the vessels under the retina, between the RPE and the retina. And here it is. This is what it shows like. Okay, you have basically stuff that is going through the RPE under the retina. You can have clear subretinal fluid if it's not too chronic. Okay, you have an elevated ellipsoid zone, but the CNV lesion is above the RPE. Okay, and the RPE may not be detached. Here you have the Brooks membrane, the RPE, and the RPE looks like it's intact. Okay, that's a classic CNV. Here again is one of my patients who has a classic, I mean, it has a combination actually, he has it, but he has an element of a classic CNV. Look at this area. Okay, all right. So basically you have a hyperreflective lesion that's breaking through the RPE and under the retina. And here you have an intact but irregular RPE that is slightly elevated from the rest of the Brooks membrane. Okay, so you've got a double layer sand. In addition, you have an area of geographic atrophy. This is a chronic case actually. So you already have some geographic atrophy. And here you have basically what looks like blood. Okay, and since this is the RPE, therefore this must be the ellipsoid zone, and you have blood under the retina. Okay, the hyperreflective. So this is a complicated OCT to understand, but I just want you to show you that a classic membrane, you can see the hyperreflectivity and the fuzziness, under the neurosensory retina, between the RPE and the neurosensory retina immediately. Okay, now this is a patient who had, again, AMD with lots of drusen. All right, you can see the elevation here. But then when you look here, you can see the elevated drusen and then a little bit of a space. And this is a little bit of subretinal fluid. This is the earliest sign of a subretinal fluid of an active membrane. Okay, this was a classic membrane right here. Okay, how do I know that it's classic membrane? Because when I went in and I did another line of OCT, I noticed that there is fuzziness on top of the RPE, not under the RPE. So I know that he's developing a classic choroidal neovascularization, and here's that subretinal fluid. It's fuzzy. This was enough for me to go ahead and treat, and the patient is being treated with monthly anti-VEGF treatment to keep his eye, because his other eye is actually lost because of disciform scarring. Okay, so here is an example of a patient who has AMD. Okay, with lots of exudation. There is this area here that actually shines up very early throughout the fluorescein angiogram, and then in the late stages it actually leaks. It becomes bigger in size and it's fuzzy. Okay, so early FA, late FA, early leakage, early hyperfluorescence with late leakage. This is a definition of a classic CNV, a very aggressive type of CNV that needs to be treated immediately. However, here in this area, you have a speckled hyperfluorescence. You can't really tell where it starts. You know that there's some hyperfluorescence, irregular hyperfluorescence, but not very obvious. But in the late frames, yes, it does show and it becomes fuzzy. This is what we call an occult CNV. All right, so this part is classic. This part is classic right there. Okay, you can delineate it with a pencil. You can draw it with a pencil, and it actually becomes very fuzzy and hyperreflective. While here, you can't really draw it very well, but you suspect that there is something abnormal because it doesn't look like here or here. And then, in fact, it leaks in the end. That's an occult membrane. So an occult membrane, an occult CNV, is a membrane that develops under the RPE. It doesn't go through the RPE. If it goes through the RPE, it's classic. If it just continues to leak, but it's under the RPE, it is occult. okay? And here's an example of an occult membrane. Here's the RPE, and if you notice, the RPE kind of elevates, okay? It elevates and it comes corrugated like this, and here is the membrane under it, this hyperreflective stuff, you know, that you see under it. Just on top of the RPE, between the RPE and the neurosensory retina is subretinal fluid. Here you have a drusen. Here you have intraretinal fluid. And here you have, basically, if you follow this, you can see that this is the neurosensory retina right there with shaggy photoreceptors. It still has some subretinal fluid, but it also has the subretinal hyperreflective material that we call SHREM, okay? Subretinal hyperreflective material, okay? Which means basically fluid that has become yellow and murky and dirty, okay? But this is the membrane. This is how an occult choroidal neovascular membrane would look. You would have hyperreflective stuff under the RPE, and then you have all sorts of intraretinal and subretinal fluid that can be either clear or not so clear, okay? That's an occult membrane. Again, here is another example. Okay, you've got intraretinal fluid on top of atrophy with reverse shadowing, and here you have the RPE that's elevated. Okay, but it's also hyperreflective. So you know there are vessels growing under the RPE. Here it is. Okay, RPE that's elevated and hyperreflective vessels growing under the RPE. So that's an occult membrane. Here is a membrane that is partially cicatrized. Okay, it still has some activity because you can still see subretinal fluid. Okay, but what you see if you look carefully, okay, maybe this is difficult for you, but you will sometimes see layers of hyperreflectivity. This is a scar that kind of built, you know, on top of each other. You've got scar over scar over scar. You have the multi-layered pigment epithelial detachment. Okay. Now, one interesting type of CNV is the polypoidal variant, which are polyps in the choroidal circulation that behave like you know, occult membranes or that behave like choroidal neovascularization. They are, in fact, choroidal neovessels, but they're kind of larger, okay? And they tend to grow under the RPE. Polyps, again, are just like occult choroidal neovascularization. They develop under the retinal pigment epithelium. And you can tell sometimes just by simply, okay, clinically, they will look like, sometimes you see these orange, you know, areas. Sometimes you don't, but you see hemorrhages and you see, you know, hardular exudates. And you can definitely see them on an ICG if the ICG technique is good. But sometimes you don't need an ICG. You can really detect a polypoidal vasculopathy, PCV, just by an OCT, by you know, paying attention. As I said, it grows under the RPE, so you're going to see that the RPE is elevated, but often it becomes, you know, irregular. It has this W sign or the QRS sign or the M sign. You know, people have called it different names, and the polyp grows right under the surface of the RPE, right there. So this is Bruch's membrane. This is the, you know, elevation of the RPE, and here's the polyp at the undersurface of the RPE, right there, or right there. Again, okay, a little bit of subretinal fluid here, and here's another, you know, example of where, you know, you can see Bruch's membrane going down. Okay, and you can see the RPE starting to elevate, and here it, oops, up and down. And if you look very carefully, you're going to see a cluster of these oval-shaped, you know, cysts that are stuck to the undersurface of the RPE. That is you know, a polyp. Okay, very clear here. Again, this is taken from a very beautiful article that appeared, you know, that was done by Dr. Ghazi and colleagues on polypoidal vasculopathy in the clinical ophthalmology. Yeah, so that's the reference if you want to read it. It's from cases from Kekish, beautiful cases. So here again on an ICG, you can see the polyps. Okay, these choroidal vessels that are large and are exuding. And if you look at if you do an OCT, you can actually see them. You don't even need an ICG. Here they are. You know, you've got an irregular pigment epithelium, and you've got all these, you know, polyps right there. There's a polyp. Here's another one. Here's another one. Okay, and here's another one. They're at the undersurface of the RPE. Okay. Now in AMD, sometimes you have the RPE is elevated and so much under pressure, under stretch, that it rips. Okay, and when it rips, it causes like an accordion. Okay, basically like a door, you know, that you that is under stretch, and you open it, and then it becomes like this, you know, a plissé kind of. So here you have this RPE that is wrinkled right there, and then here you have loss of the RPE. So the whole RPE kind of under stretch, you know, goes to one side. It denudes the choroid and the sclera underneath, okay, right there. If you do a picture, sometimes it's associated with blood, all right, and usually with an acute vision loss. And here it is. So this is typical of an RPE rip, okay, when you have this zigzaggy appearance followed by a loss of the RPE, okay. Now, CNVs that occur in myopia or that occur in inflammations tend to be type 1 CNVs. They tend to grow between the RPE and the neurosensitive retina, and they tend to be smaller. So they don't have these, huge lesions that you see in AMD, okay? Now, can anybody tell me what this lesion is? This is a deep lesion. What is this lesion? What do you notice? I'm giving you the picture and I'm giving you the OCT. Does anybody know what this is? Walid say GA. Well, I think you're saying GA because this is atrophic, but notice Walid how thin the choroid is, okay? And notice that you don't have inverse shadowing. Okay, so if you had GA, you will have this area would be much brighter, but actually you have a little bit of shadowing. You don't have inverse shadowing. And notice that the RPE is, yeah, somebody said thick RPE, somebody said, well, not telangiectasia, but RPE, yes, it is a problem with an RPE. It is a very hyper-reflective RPE. So it is a thickened RPE or a hypertrophic RPE, okay? So yeah. So this is, and this is what we call a congenital hypertrophy of the retinal pigment epithelium. Here it is, okay, a chirpy, which you guys know by the name of chirpy, but congenital hypertrophy of the RPE. And it's in the periphery. And we know that it's in the periphery because the choroid is thin and because the retina is thin, okay? So the retina, we know that the retina is thin in the periphery, right? So yeah, so this is a thin retina, and this is a hyper-reflective RPE that actually shadows a little bit posteriorly instead of inversely shadowing. Okay, last, we're almost finished, are the choroidal pathologies, just a few words, because we tend to do an enhanced depth imaging instead of a regular OCT, to understand the choroid a little better. And of course, if you do a sweat source, then you can really, see the choroidal structures much better than with the regular one. But let's say you have a standard OCT, what you can see with OCT is the thinness of the choroid. In this case, obviously, okay, it's very thin. Okay, it's almost paper thin here. You can see the sclera that has no vessels. You can see the big choroidal vessel here, that is almost like a varix, but actually it is just a big choroidal vessel that is so close to the retina because there's hardly any inner choroid left, okay? The retina itself has a normal stratification, normal architecture, but everything is thin. This is age-related choroidal atrophy. Often people like this, when you see, these patients, these elderly patients, they have this hypopigmented fundus. The choroid is atrophic and you start to see the choroidal vessels, and a lot of people will tell you, oh, myopia. Actually, no, this is not myopia. The reason you think it's myopia is because you can see the choroidal vessels very clearly, and they share the same thing as with myopia, which is the thinness of the choroid. But actually, you don't have the staphyloma, you don't have the peripapillary atrophy, you don't have the discs. In general, the vessels are quite thin, okay, which I agree can happen in myopia, but the optic nerve is often quite pale, okay, and not tilted and with no staphyloma. This is age-related choroidal atrophy. It's caused by hypoperfusion, age-related hypoperfusion of the choroid, okay? The choroid does not get so much perfusion, and oftentimes that people do have, loss, they complain about, their vision not being as good as before, especially in the dark, okay? Now, choroidal folds, you can also see on an OCT, all right? I don't think there's any difficulty here. You can see how the RPE and the choroid, everything goes up and down very nicely. The choroid is of nice thickness, okay? The retinal stratification is normal and it just follows the folding, okay, without loss. And on the fluorescein angiogram, you can see the folds with these alternating line of hypofluorescence, hyperfluorescence. The hypofluorescence is usually at the crease of the fold, that's the bottom of the fold, and the apex of the fold, where the fold is highest towards vitreous, that's cause, you have a window effect causing the hyperfluorescence. There's something in the chat, looks like drusen. Okay, well, I'm glad that you said that. The reason why it's not drusen is because you can't see the you cannot see the Brooks membrane, can you? Okay, and I understand why you say that, but if you follow, you'll see that the choroid itself follows this up and down appearance, right? The choroid seems to follow the RPE. The choroid doesn't stop here, and then you have, you know, a line, a thin line that is a drusen. Let me go back, because you guys need to understand this. So you see, this is drusen, okay? This is drusen. The RPE, the Brooks membrane is intact. The choroid doesn't go up and down. Again, here, same thing, but maybe this is not so clear. Here, for instance, here you have drusen. Notice how the choroid is intact, okay? You have a little line. Here you have a little line that you see. What else can I show you? Yeah, hold on. Yeah, I showed you drusen before. I hope I'm not missing them. Yeah, this is drusen, okay? So you've got the RPE right there, elevated. The Brooks membrane is intact, and the choroid doesn't follow. You can see the elevation. But in this case that I'm showing you now, this is, the choroid goes up and down, okay? And you don't see that white line. So yeah, it is, you know, you can clearly see the difference now that I've explained it, then you can see it, I hope. Okay, excellent, very clear. So I made my point clear, good. And also another choroidal pathology is high myopia, okay? And with high myopia, you can sometimes see this dome-shaped elevation. The sclera becomes thick in the posterior pole. It kind of pushes forward towards the vitreous. And this decreases the axial length a little bit, you know, so it's maybe God's given mechanism of decreasing the degree of myopia. But the other signs of myopia are the thinness of the choroid, okay? The retina usually is not that thin, but sometimes the retina can have, you know, subretinal fluid, and can have schises and, you know, epiretinal membranes and all sorts of things that we are now discovering in myopic, in highly myopic eyes, what we call different degrees of myopic maculopathy, okay? But here, this is an example of one in which there was intact, you know, retina, but just a very thin choroid and a dome-shaped macula. Choroidal ruptures after trauma will look something like this, okay? You may have an interruption of the ellipsoid zone, okay, and sometimes the RPE kind of dips backwards, okay? You're like a rent in the RPE. That's, you know, this is a typical case of a choroidal rupture. And a torpedo maculopathy, which is a congenital abnormality of the retina, where there is excavation of the RPE and the choroid, okay, can look like this. This is our case. Here's a torpedo maculopathy. It looks like a torpedo, okay? It's usually on the horizontal raphe, usually temporal to the fovea. Okay, so it's in the temporal macula along the horizontal raphe, and it can be very subtle, such as this, okay, or it can look, or the excavation can be much more obvious, all right? So backwards bowing. And finally, I think this is the final, yeah, the choroidal hemangiomas and tumors of the retina, where you, the OCT can show, you know, the bulging, can sometimes show the hyporeflectivity, and oftentimes it shows the outer retinal problems, you know, that happen with choroidal tumors, such as, you know, fluid, you know, and RPE atrophy from constant, you know, fluid input. Okay, so I think we're done. Yeah. And so we have a few minutes for questions, but basically, you know, I'm sure you guys know that now this OCT for us is a no-brainer. You know, you need this for the diagnosis of macular diseases. Of course, you have to know that we can do OCTs outside the macula, okay? But of course, it requires a good technique and a very cooperative patient, you know, to center the OCT in the area where you want, to give you more idea, you know, more information about the structure. But usually most of the time we just do a macular OCT, okay? So understand the macular function and the macular pathology. So it shows you also whether you think whether you know, the macular function is equivalent to what you expect. When you see like certain structures on the OCT, that you can actually more or less predict the acuity of the eye just by looking at the structures, if they're intact or not, okay? And of course, when you treat patients, you follow them with OCT to see if your treatment is helpful or not. So of course, but in order to interpret and to use the OCT, of course, you have to pay a lot of attention to the technique. So be careful with the artifacts, okay, that I talked to you about. Make sure that there are no artifacts, and if there are artifacts, know that you cannot use just the map, okay, to to make a decision, all right? And you have to also know the reflectivity of tissues and know what is normal, so that when something is abnormal, you can detect it. And always review all the scans. Do not just rely on the central line scan and that's it. Review the whole raster scan so that you get a good idea of what the retina has to offer. Okay, so we have a few. Yes, clear. What are the conditions that are associated with RPE-RIP? Well, AMD mostly, okay? Mostly AMD, but anytime that you have an RPE detachment under pressure, it can rip, okay? So you have a huge serous retinal detachment, yeah, it can rip. If you have an AMD with a big RPE detachment, of course it can rip, especially if it has, whether it has fluid, just regular fluid, or even, you know, blood. If you have a big RPE detachment and you do anti-VEGF, or if you do laser, or if you do PDT, you can actually hasten the rip. You know, you can actually bring it, you know, trigger it if you wish. That doesn't mean that you should not treat patients with anti-VEGF or with PDT if you have big detachments of the RPE, but you should counsel the patient and you should know that it may happen, okay? But it can also happen spontaneously without any treatment. All right, so who has questions? This is a good time to ask.
Thank you, Dr. Sawsan. Just I have a small question. When you label diabetic macular edema patients with central or non-central involved DME, do you depend on the central subfield thickness, or do you depend on the morphology or the qualitative assessment of the OCT?
They're the same. If the I basically look at the scans, okay, one by one. I always look at every single scan in the volume and try to decide how close that is to the fovea. All right. If it's close, very close, then of course it's center involving. And in general, if the map is correct and the segmentation is correct, okay, then the subfield thickness is going to really be reflect what I'm seeing, okay? But if I look at the scans and I see that there is center involving or let's say non-center involving diabetic macular edema, I think that the cyst or the thickness is a little bit far, and then I see on the OCT map that the central subfield thickness is high, okay, then I start to look carefully whether the map was taken, you know, with the central fixation or not, or whether it was off center, okay. But basically, I just rely on the lines. Most of the time, I don't even look at the map, okay. I just rely on the lines to see how close the thickness is to the foveal center, and I tend to treat even if it's not close to the foveal center, depending on whether I see microaneurysms there or not. If I see, for instance, a thickness that is, you know, can satisfy the criteria of a clinically significant macular edema, but it is not in the center of the subfield, but it can endanger the subfield, I may sometimes start to do a laser treatment, okay, to those microaneurysms very lightly, to prevent the egress of the macular edema to the center. The lines don't lie, okay? The lines of the volume don't lie at all, but the map can be wrong when the segmentation is wrong or when the centration is wrong. So I rely on the lines, but if the lines are correctly, the segmentation lines are correctly put on each line of the raster, and if the scan was taken really at the, you know, with the central fixation being in the center subfield, you can rely on the central subfield at that point.
Thank you, very clear.
You're welcome. Anything else? This is the time to ask, guys. You're welcome. Anybody else? Okay, guys, I'm going to give you 2 minutes and then I'm going to be off. So it's 16:58. So we did it on time. That's nice. The more you guys look at during the you know, the clinic experience, the more you'll learn. So it's it just comes with practice. But as long as you know the basics, it should come with practice. Okay, so I guess there are no questions. So I'm gonna say good night and thank you for listening, and maybe see you at another lecture. Bye-bye.